All right. Well, thank you very much. And thanks to my co-speakers as well. It's a pleasure to present this webinar series today. So I wanted to cover the arteriovenous malformations of the fetal brain and sort of point out some of the recent developments and the importance of the steps to do a diagnosis, the prenatal risk stratification, and describe the early outcomes with fetal therapy. So fetal cerebral vascular abnormalities are subdivided really into 3 or 4 different entities. So the most common one is the vein of Galen malformation. Then there is a non-galenic arteriovenous peel fistula, a dural sinus malformation, and then an intracranial venous malformation, which in some texts is grouped with these, but it's really a separate entity in itself. Before we talk about fetal AVMs, it's important to bring back some important basics about cerebral blood supply. So you may remember from your anatomy that the cerebral blood supply is by distinct arterial fields where there is watershed areas where the supply territory is in overlap between different arteries, and they're quite specific and quite reproducible. And the venous drainage is basically by a superficial and an inferior venous drainage system that ultimately goes via the sagittal sinuses, the transverse sinus, and then into the jugular veins. Anytime you have an arteriovenous malformation, there are some potential consequences that depend on the magnitude of arterial to venous blood flow shunting in that lesion. So because the veins are a high capacitance circulation, they can actually accommodate quite a lot of arterial blood flow. So you might see a lot of venous return increase to the heart. And so the heart would definitely work harder, and it does increase the cardiac output. The cardiac output increase also has sort of, an effect on the arterial circulation, and with increase in fetal blood pressure and all that, there might actually be increased preferential streaming in the arterial circulation in the feeding vessels of an AVM into that AVM. And so you get sort of a vicious circle that you get high output cardiac failure, increasing bypass of arterial blood from the brain into the AVM. And for the fetal cardiovascular system, the combination of high output cardiac failure with an increased venous return also predisposes to abnormal pulmonary circulation development and pulmonary hypertension after the baby is born. The other thing that happens is because of the arterial stream, because there is preferential blood flow in the fistulous arterial connection, you actually get arterial stream steal from the brain parenchyma. And especially the areas that are part of the watershed areas in the arterial circulation are at risk for hypoperfusion. And the increased venous pressure also predisposes to venous stasis in the microcirculature and accentuates the bad and suboptimal cerebral perfusion. And this is sort of the reason why there is progressive brain substance loss, and the term that has been framed in the context of fetal AVMs as the melted brain syndrome, as more of the cerebral neural matter just really deteriorates. In addition, there are other risks that exist depending on the type of AVM. So if you have one that has a lot of small vascular, sort of choroidal type AVMs, you can get actually intravascular consumptions of clotting factors. You can get thrombosis in areas of venous stasis, and that might lead to an acute change in the dynamics of blood flow, both within the brain, but also in the whole circulation. So although it is a localized lesion, it has really the potential for causing a multi-system disease in the fetus. The three main AVMs that we know are the vein of Galen malformation and, like I said, the Peel AV fistula, the dual silence malformation. The embryology of the first two is really abnormalities in vascular development. The etiology of the latter form isn't completely known, and both the vein of Galen and the Peel AVMs, they are associated with single gene locuses that are involved in vascular sprouting and you know how vessel development happens in the period of vasculogenesis in the fetal brain. The feeding arteries for the vein of Galen are typically choroidal or middle cerebral that drain into a persistent Falcine sinus or the straight sinus. The vein of Galen is actually a misnomer because this vein that is dilated is actually an embryologic remnant that is supposed to normally disappear, and that doesn't happen. In a Peel fistula, there's a Peel artery to a Peel vein, and in a dural sinus malformation, it's usually an artery feeding into a cortical vein or sinus. And the clinical features basically in the vein of Galen malformation is a high risk for high output cardiac failure and the melting brain syndrome. Peel fistulas can also give you high output cardiac failure, but typically less frequently so in fetal life because they are typically smaller, more confined, more towards the brain surface, and often don't have the potential to sort of receive that much arterial blood flow. And therefore also it is less frequent to present with brain abnormalities. And dural sinus malformations have been linked with high output failure, but they typically don't cause the type of damage of the brain in fetal life that we see for the other AVMs. And sometimes they can spontaneously regress because of the large venous lake thrombosis. It might actually decrease the flow. The prenatal diagnosis of these malformations is really possible from 26 weeks onwards, but in most health systems where there is no specific brain anomaly screening protocol as part of your anatomy ultrasound, typically the diagnoses are made in the third trimester. And of these abnormalities, the vein of Galen sort of accounts for 30 to 40% of the fetal anomalies that we see. And the overall prevalence was once thought to be about 1 in 30,000, but in reality, they might actually be more common than that because they also get diagnosed more frequently. So the hallmark of an AVM really starts with that on grayscale ultrasound, you see a hypoechoic area. And the vein of Galen aneurysm is typically a midline structure. The Peel AVMs, they are typically more peripheral, but they can also be midline if they extend downwards from the pia mater that is superiorly. And the dural sinus malformations are typically surrounding an area where anatomically the major sinuses are. It is absolutely essential and key to use color Doppler because that's the only way you can distinguish a vascular lesion from a lesion that might be due to just a fluid-filled area, like, for example, arachnoid cyst or something like that. So that is essential. Whenever you see an AVM, the next important step is to look at the cardiac function, look at the cardiothoracic ratio, look at evidence of heart failure, tricuspid regurgitation, and measure the combined cardiac output normalized for estimated fetal weight, because those are prognostically important markers. You can often on ultrasound get a hint that there might be increased venous return because there is preferential dilation of the superior vena cava, as you see in the bottom right. Venous Dopplers are important to look at the forward function of the heart, and then looking at either the aortic isthmus or the descending aorta, because these lesions predispose to something that's called the arterial steal. So this is the blood flow in the descending aorta. And what is actually happening here is that during systole, the blood flows forward to the placenta, but there's so much blood flow into the AVM that there's actually reverse flow in the aorta back into the circulation and into the cerebral AVM. And this arterial steal can propagate its way all the way to the placenta. MRI is essential for the more detailed definition of the brain anatomy, as well as diffusion weighted imaging, to get an idea about areas of hypoxia or perfusional compromise in the brain. There are two important studies that look sort of at prognostic markers. One is the multi-center series from Europe, where they basically looked at the overall volume of the vein of Galen malformation, the dilation of the straight sinus, associated brain abnormalities, and cardiovascular findings. This is a group of patients where there was a high rate of termination of pregnancy. And in this study, the important predictors of prenatal brain damage was really the volume, the overall size of the vein of Galen abnormality. Poor outcome in this study was defined as a composite variables of the ones highlighted here. And when they looked in their overall predictive model, the venous volume of the vein of Galen AVM and tricuspid regurgitation were really the most important stratifiers for patients that were likely to have a bad outcome. Straight sinus dilation was also important, but it wasn't further quantified in an absolute cutoff. This is a really important study from the Boston group, which basically looked at the minimum medial diameter of the falcine sinus in a vein of Galen AVM. And what they basically showed is that there's an increase in the mortality as the AVM gets bigger. There's an increased risk of right ventricular dysfunction, and that also translates into a risk of pulmonary hypertension. There's an increasing risk of ventriculomegaly and parenchymal damage, both at birth, at 1 to 3 months of age, and also at 1 year of age. And there's a progressive decline of normal development at 1 year of age. So, and this particularly goes up with a diameter of over 7 millimeters. And so they are really identified in the study the mediolateral, the falcine sinus diameter as a robust predictor of several outcomes, and also at different time points, both from fetal to 1 year of age, which is really important because that forms sort of the basis of fetal therapy. And the group also pioneered, together with some other centers, the ultrasound-guided vein of Galen embolization in fetal life. And what we do here is basically that we turn the baby into breech, give the baby a paralytic agent. It's a multi-D setup with fetal therapy, interventional neuroradiology, the OB anesthesiology team, but also the NICU and L&D teams. And basically, we cannulate the falcine or the straight sinus with an 18 gauge, then put a vascular catheter in, and then coils are deployed. And here is a video of what that looks like in real life. So this is a procedure we did at 32 weeks. You see the 18 gauge needle in the falcine sinus via a transtorcular approach. And now I'm taking the obturator out. And the next thing is that the deployment catheter gets placed. And once that is placed, we successively place coils, and this is done by Professor Gaillou. So he's the one that operates the coils, and he's the one that basically decides how much to occlude the venous sinus. And we talk a little bit more about that later on. And then, once you have reduced the flow, then you remove everything again and let the baby wake up. Now, this is a summary of all the cases that are reported, including the ones, the one that we have done at our center. So overall, the gestational age of surgery is actually relatively late, and that's important to consider. It's about 34 weeks. Some cases have been done earlier, but they happen in cases where the diagnosis was done at 26 weeks. The technical success is almost 90%, and the later ones are harder because the fontanelle might actually be a bit smaller. Average gestational age at delivery is 37 weeks. The other important thing is that the majority of cases will require re-embolization using different techniques after delivery. The overall survival is 43%, and the intact neurodevelopment in the survivor is 83%. So from a prenatal perspective, the risk stratification that we use is we use ultrasound, fetal echo, and MRI. And babies that have no brain abnormalities and a small lesion overall have a good prognosis and can have term delivery. Once you get an increased volume in the vein of Galen, then you are still at good prognosis, but you are at risk for progression of either cardiovascular or brain abnormalities prenatally. And you might consider an earlier delivery for postnatal shunting. Once you get tricuspid regurgitation, this correlates highly with pulmonary hypertension and is associated with poorer prognosis. And if on top of that, the vein of Galen is large in size, then a poor prognosis is highly likely. In the presence of CNS lesions, the prognosis is overall poor. And these data or this kind of algorithm comes from the Palladini group, where poor outcome was also classified as the group of patients that shows termination of pregnancy. And obviously there's the palliative care path in this setting as well. The importance of the venous sinus measurement of over 7 millimeters is it gives you an idea about patients that might benefit from prenatal intervention. The other thing that's important, so normally these patients can deliver vaginally. Whatever we do at delivery, we want to make sure we leave a long umbilical cord segment, which facilitates the placing an arterial line for umbilical arterial access. So in conclusion, fetal cerebral AVMs have potential multi-system risks with devastating impact. The really multi-modality and detailed prenatal assessment is important. And in specialized settings, the embolization, prenatal embolization and vein of Galen malformations may benefit some interventions, and in a trial for evaluation of fetal therapies is ongoing. Thank you very much.
And are you able to see my slides?
Yes.
Thank you, Dr. Bashat. Hi and good afternoon. I'm Cecilia Kwok, one of the neonatologists here at Hopkins. It's my pleasure to join Dr. Bashat and Dr. Gayu today to talk about caring for babies with vein of Galen malformation. So Dr. Bashat spoke a lot about the cerebral AVMs, and so I'm not going to go into it as well, but ultimately what you have is a massive left to right shunt. So as Dr. Bashat mentioned, you have a significant amount of systemic arterial blood flow that is shunting directly into the cerebral venous circulation, so into this vein of Galen aneurysmal malformation. And so that ends up being a huge left to right shunt. And what happens with that left to right shunt is it goes straight into the right side of the heart. So I find it helpful to follow the blood flow, which we'll try to do here. So you have this excessive amount of blood flow that is going into the superior vena cava. You'll have a dilated SVC. You can have SVC flows that are anywhere from 8 to 10 times what you might normally see in a newborn infant. And then that blood flow goes into the right atrium, which becomes dilated, into the right ventricle, which becomes very dilated as well, and straight into the pulmonary arteries. And so you have a significant amount of pulmonary blood flow that you would not necessarily have as much of, and that can increase your pulmonary arterial pressures as well. And so there is a circular nature to the shunt too. And so when you have this excessive pulmonary blood flow, it then can go through the ductus, which is typically open still after a baby is born, and straight back into that low resistance vascular malformation. And that just goes right back into the right side of the heart. And so you can see how this can lead to an excessive amount of increase in blood volume into the right side of the heart, into the pulmonary arteries. And what may not be getting the blood flow that you want it to is the descending aorta. And so you won't be getting as much blood flow into the descending aorta that supplies your lower half of the body, that supplies your systemic circulation and a lot of vital organs. At the same time, the left ventricle, which also supplies our cardiac output, the blood from the left ventricle goes up into the ascending aorta and again is being stolen by this vein of Galen malformation. So you're not having as much blood flow into the descending aorta from the left ventricle as well. And so what that means is that taking care of a baby with a vein of Galen malformation really means managing pulmonary hypertension, but it's a different type of pulmonary hypertension that we're more accustomed to seeing in the NICU, and heart failure. And so a fetus in utero is not necessarily experiencing signs of heart failure. And part of that is because you have this low resistance placenta that can be somewhat protective against the low resistance vein of Galen malformation. So there's a number of changes that happen after a baby's born. So after a baby's born, we cut, I don't, but so OB cut and clamps the cord. So there goes your low resistance placenta. And that means that you suddenly have this large volume of blood flow that can go into the vein of Galen malformation, that it can kind of steal the blood flow and just as a vacuum, like suck up the blood. At the same time, there's other changes that happen in just normal fetal to neonatal transition. So as a baby is born, they take breaths, ventilate, their lungs are exposed to oxygen, and pulmonary vascular resistance, which is high in utero normally, start to decrease. And at the same time, you have an increase in systemic vascular resistance. And so you have all this blood flow that can get shunted to the low resistance vein of Galen malformation. And you have other normal fetal to neonatal changes happening. And that means a significant amount of that blood flow goes straight into the right heart, into the pulmonary arteries, and can flood your lungs and kind of overload the right side of your heart. And so what you have primarily is a volume, like a blood volume flow related pulmonary hypertension, which is, as I mentioned earlier, different from what we're used to seeing. And this is kind of explains how a baby will present. So they may present, they could be stable after they're born, they could have a little bit of respiratory distress, but very quickly can proceed to have symptoms related to high output heart failure and pulmonary hypertension. But this is a blood volume related pulmonary hypertension. That increase in blood volume to the pulmonary arteries can lead to an excessive increase in pulmonary arterial pressure from the volume. That can then feed back and increase the right ventricular afterload. So you can have this dilated right ventricle with high pressures, then have a bit more of a stiff, non-compliant right ventricle, and that can lead to RV dysfunction. And with RV dysfunction, you can then kind of push on your interventricular septum here into your left ventricle, and that can then impede some of your cardiac output. So after a baby's born, it's not uncommon that you might see normal or even hyperdynamic LV function, but the cardiac output with RV dysfunction may not be enough to meet the baby's metabolic demands. So baby can become hypoxemic, have lactic acidosis, and respiratory failure. So this gives us a better sense of how a baby will present. It may not be right at birth, but it could be within hours, sometimes within days, depending on the severity of the lesion and their symptoms. The reason that this is so different from what we're accustomed to seeing in the NICU is that it's more typical for us to see babies who just have a delay in transition from the decrease in that pulmonary vascular resistance that they see in utero. And so thinking about this as pulmonary hypertension that is mediated by volume really dictates how we manage babies after they're born. So what do we do after a baby's born? We're starting to see these symptoms, especially if we already have a high suspicion of or have a prenatally known diagnosis of a vein of Galen and malformation. What you want to do is you want to offload that right ventricle, and that means early use of diuretics. It may be aggressive early use of diuretics as well, really trying to decrease that blood volume into the right ventricle. You could consider fluid restriction as well, but I think really you're going to start with diuretic therapy. You want to make sure to support cardiac function. Now, this might be in some cases more than others. So if you're already seeing some RV dysfunction, you're seeing impact on the cardiac output from the left ventricle. At the same time, as Dr. Bashat mentioned, you do have continued steal of blood, even from the left ventricle too, because that blood, which would go through the aorta, is also getting stolen to the vein of Galen. So if you're starting to see some hypotension, some oliguria, lactic acidosis, then you would want to consider some inotropic therapy. I'm not going to talk a lot about pressor support just because there are different thoughts. And I think there's ultimately not any sort of optimal, you can't just use these specific pressors in the management. It really depends on how the baby presents, what you're seeing on echo. You can consider maintaining a right to left ductal blood flow through the ductus with PGEs. On the one hand, if you're maintaining a wide open patent ductus, you're really worried that you're sending more blood flow to the vein of Galen malformation, and you're potentially stealing from your systemic circulation, your systemic perfusion. On the other hand, if you have suprasystemic pulmonary hypertension, you're having some evidence of more steal from your systemic circulation, you might want to think, one, can you help offload the pressure on the right ventricle by having an open ductus and trying to make sure that it stays open by initiating PGEs? And on the other hand, even though you have a lot of blood that may be going through the ductus back into the AVM, hopefully you're also having some of that blood flow into the descending aorta. So you might be somewhat reliant on that blood flow through the ductus into the descending aorta for systemic circulation. And I know some folks kind of think of it as a pseudocoarctation type of physiology, or can become a pseudocoarctation type of physiology. You want to be quite judicious in the use of oxygen. So ultimately, often when we're thinking about resistance-mediated pulmonary hypertension, we're thinking about using pulmonary vasodilators, but this is such a different scenario. And so you want to be cautious about using pulmonary vasodilators, and oxygen is such a potent pulmonary vasodilator because you could just flood your lungs. And so you might want to use lower sat limits, maybe 90 to 95% versus a higher sat limits that people often use in PPHN management. So after all that, there's still a question, is there some resistance-mediated pulmonary hypertension in babies who have vein of Galen malformation? I don't know the exact right answer, but it does seem like there may be a mixed phenotype here in some cases, and perhaps more severe cases as well. And the thought behind that is that there are some cases from lung pathology from autopsy, as well as some of babies who had vein of Galen malformation, as well as from animal models as well, that do show some pulmonary vascular remodeling. So the thought is that babies, fetuses who did experience high volume pulmonary blood flow in utero maybe experience some remodeling of their pulmonary vasculature. So there might be a component of intrinsic increased pulmonary vascular resistance as well, but it does still seem like babies who present early, there's such a significant component of volume mediating pulmonary hypertension. So ultimately, maybe there's some in there. It's hard to know for sure, but still I would still manage it more like a volume mediated pulmonary hypertension. Speaking about that, then we think about the pulmonary vasodilators. I talked about oxygen, but now I just wanted to mention inhaled nitric oxide as well. So overall, pulmonary vasodilators are not routinely recommended, and initiation of inhaled nitric oxide is also not routinely recommended in management of these babies and their pulmonary hypertension. I think there's been some evidence that shows that it can worsen high volume pulmonary blood flow. So you are going to vasodilate those pulmonary arteries and just flood your lungs. You could potentially then worsen systemic hypoperfusion, so worsen lactic acidosis, worsen hypotension. And so I think overall, many cases have shown that there's limited benefit, and you can worsen things for the baby. And so I think ultimately we don't routinely recommend it. If in some severe cases that does happen, you just have to be ready that if you're seeing worsening systemic steal, to stop that because it's not working. So, as Dr. Bashat mentioned, this really is an interdisciplinary collaboration. So if there's a prenatal diagnosis with fetal therapy teams with Dr. Bashat and his team, us from neonatologists with Dr. Gayoud, neuroradiologist, we really are looking at the imaging, trying to get a better sense of how severe the baby might present after they're born. Can we potentially come up with some sort of delivery plan and maybe even some initial thoughts about a post-natal management plan? And we really want to be able to work together to talk to the family of what they might potentially expect. Although really babies present so differently sometimes, it's hard to know exactly how they're going to present, the timing of their symptoms and the severity, and ultimately there's just so much uncertainty. After a baby's born, it's truly essential to work together as much as you can as a team. we work a lot with cardiology and ideally can have serial echo imaging to see like how are these cardiopulmonary dynamics changing after a baby's born. Do you have a better sense of, is there some resistance mediated pulmonary hypertension, or is this all of this volume and how much volume? And as you initiate therapy too, to be able to do those serial echoes to see what the effects of are the therapies that you're using. The timing of embolization is challenging. So there's so many reasons that it's best for a baby to be able to wait if we can medically manage heart failure till they need embolization as they get bigger or older. But at the same time, other babies will need urgent embolization. So as soon as a baby is born, or even before then, if we know the diagnosis, Dr. Gayud is involved. And we really are talking about when is the best time for embolization. I think it's really important to work as a team to clarify the therapeutic goals, not just for us as a medical team, but for the family as well, because this truly is a very long journey for families. For those that have a prenatal diagnosis, it starts several weeks to months before a baby is born. And after a baby is born, there's so much that's just changing in terms of the blood flow dynamics between the brain and the heart, in terms of how sick a baby is going to be. If they get to the point of an intravascular embolization, there's stages of embolization that Dr. Gayud is much more well-versed in talking about too. But babies can be sick for quite some time, and it's a long road. And from a neurodevelopmental outcome perspective, it really does vary, and there's a wide spectrum. So we try to keep the families informed along the way and really speak together to them as a team. Just want to thank you for the time, and I'll pass this on to Dr. Gayud.
All right, so I'm going to be relatively brief. There's not a lot to add to what we just heard, but I think it's important to understand that vein of Galen aneurysms are really two different categories. There are the kids who present really early, and we have been talking about them so far, and they have the high flow output. They're very sick from the start, and those are the ones who have the most likely bad outcome. And so those who go to the NICU, require all this extensive management are the high risk cases. And then on the other side, there are kids who have minor symptoms, oftentimes not even diagnosed, get diagnosed a bit later in life, sometimes around one year old, sometimes later, and some diagnosed at the adult stage. And that's a completely different, although it's the same pathology, it's a really different presentation that makes it almost two different disorders. I'm going to show you some example of both types. But the first thing I would like to mention, because in terms of treatment, it's absolutely critical, it's that normal drainage. I know, Ahmed, can you see my arrow moving?
Yes.
Yeah. So we discussed the vein of Galen, the sac of the lesion, which needs to be treated. But what needs to be understood is that the normal venous drainage, you see here a basal vein and here an internal cerebral vein, they can still be connected to that sac, and they are almost impossible to detect, both with angiography, with MRI, MRA, all the techniques we have. It's almost impossible to say if those veins are here or not. And based on some extensive anatomic work, notably by Charles Rebaud, who is the true expert on that disorder, we know that probably about at least 40% of those babies have at least one connection to the deep venous system. And without that, if we didn't have this, it would be a really easy disease to treat. We would just go there, close the sac, like you see here, for example, with all those coils in. Simple procedure, rapid procedure would be done, and there would be really not much to think about. The problem is, if we do this, and you see that example with the coils, we're going to occlude those normal deep draining veins. And that leads rapidly to deep venous infarction, hemorrhagic conversion, and death. And so we know from experience in the early endovascular days, if you just go simply there and pack this large vein with coils, you're going to have a great result for 24, 48 hours, and then the baby is going to die pretty much after that. So what are the therapeutic options? First, surgery is not an option. Before endovascular treatment, the mortality of this newborn with the very active disease was 100%. Nobody survived. And only with endovascular treatment, we start to have some survival. But ideally, you want to close the feeding arteries and keep the venous drainage open. And so we can use, my favorite embolic agent for that is to use a glue, a very fast sealing glue. We come through the arteries, so it's a transarterial embolization, close the vessel and leave both the sac and the deep venous drainage untouched. Now that's easier said than done, because when you close the veins, the sac is going to close as well. Now, once there is no more afferent flow, there is no more flow in those very large sacs, they're going to thrombose, and that's the main fear we have, is diffuse thrombosis that can progress, even extend in the sagittal sinus, in the transverse sinuses, and cause a disaster. Very briefly, there are two main categories of architecture. There's the large shunt dumping immediately in the sac. We call that the mural type. And a pseudo-nidus. This looks very much like an AVM, but it's not. It's only a lot of small feeders called the choroidal type. And this is usually a slower flow. So those are the kids that tend to present a bit later, while the ones who present very early with major cardiac and respiratory failure are more of this type. In reality, you always have a little bit of both types. Those are two extremes. They rarely completely separate. And a quick angiographic image, this is the high shunt choroidal type. This is the pseudo AVM appearance of the choroidal type, and should not be confused with this, which is a true AVM. You see an AVM of the corpus callosum draining in a very large vein of Galen, but this is not a vein of Galen aneurysm. It's a completely different disease, not to be confused with this type of lesion. So a few examples. This is a 4-month-old that was known to have a vein of Galen relatively early, was very stable, followed normal developmental guidelines. So we did wait a little bit. I think we learned about him about 2 months, and we waited a little bit more. And here he comes for his first intervention. You see a relatively large lesion. And this is a purely transarterial treatment. So here we have already done a couple sessions to close some of the vessels. You see a few coils, a little bit of glue has been placed. And this is before his third session. Now here, there is no choice. There's only one feeding artery left. So we're going to have to close it. And unfortunately, there's still a relatively large sac. You know, the idea you heard before is you don't want to be too abrupt. If you close everything too abruptly, not only you put a severe strain on the cardiovascular system, but you really risk that diffuse thrombosis problem. So here he comes for his third session. This is pre and post embolization. You see that the vein of Galen is treated. It's a cure angiographically. But this is what happened right after. This is before treatment. We have just blood in the sac. On day one, we have the clot starting to form, even with a blood clot level here. And then despite anticoagulation, this completing of the thrombosis, you see the straight sinuses thrombose. And in that case, it even went in both transverse and into the jugular veins. And that's under maximum anticoagulation. By the way, the shunt was placed before treatment, and really try to avoid placing shunts in these kids because it's usually avoidable, and that's a typical situation. So this kid sounds like a catastrophic event. We were lucky because there was no normal drainage in that vein, so there was no deep venous infarction. And he did actually pretty well. This is 3-year follow-up. He's developmentally normal. You see here the vein is slowly getting back to a normal size. The thrombus will take several years to really get organized and shrink, but this is a good outcome in spite of that significant event. So that was purely arterial treatment. Usually we try to combine arterial and transvenous. So for the transvenous, you can either go through the artery because they're large enough and pass the microcatheter inside the venous sac and start to treat the sac, or come through the jugular vein backward. In this case, you would go transverse sinus, jugular vein, falcine sinus, and then the sac. So this is pre and post treatment. This is again a case that went really well, a complete cure. This is a kid that came to us at about 1 year old, 14 months old, because of enlarging head circumference that led to the diagnosis of hydrocephalus. We did a few transarterial embolizations. You see here the glue in the vessels, a little coil in an artery. And all these first embolizations were 2 or 3 sessions, I don't remember, were transarterial. And once you reach a point you feel you cannot add safely to that, and that's the point here at that session number 4, we feel that there is no vessel that can really safely be taken, then we go transvenously to finish the treatment. Those were supposed to be movies, but sadly they don't play. But what they show simply is that we use very small devices. This microcatheter here is 1.2 or 1.5 French, depending on what we use, which means a French is a third of a millimeter, so about 0.4 to 0.5 millimeter size catheters. Drop a coil, and if the movie had worked, you would have seen the glue come out and get stuck in the coil to seal that feeding artery. Trying to go forward, here we go. So that was done. All the transarterial treatment was done. This is the transvenous embolization. You see coils of a larger size now placed in the sac. And the control angiogram shows a complete obliteration of the lesion. This is pre and post treatment. It's a really good outcome. At 3 years, we're happy with that. The coils will remain in the sac, but even if it's treated late, you see it was a kid treated for hydrocephalus at about 1 year of age. You can see that the ventricle size decreases. It's still a secondary hydrocephalus. There's a lot of literature saying after 6 months you cannot correct anymore. But as you can see here, even at 1 year, there's still a good effect on hydrocephalus. So those are the easier ones to treat. And this now is more the case we have discussed so far of newborn with catastrophic presentations. And those will not do well or rarely do well. And by doing well, I mean having a completely normal lack of sequelae, normal life, neurologically intact. And you can see why. You have this extremely high flow lesion. You see the arteries are very big. The venous drainage is tremendous. They usually have associated issues. This kid, one we treated recently a few months ago, came to us at day 3. We tried to wait a little bit to see if the medical management can help, but at day 6, he was going down. So we need the first embolization. And now you have to make a decision which way you're going to do. Transarterial is my favorite access normally, but in this case, it's a hectic situation. You're in the end room with a 2 or 3 kilogram baby. There's about 15 or 20 people in the room. That's probably the largest ratio between the weight of the baby and the number of people involved in the case. And it's very hectic. And you know, the main thing you're told by the anesthesia team is we are here. We don't know how long we can stay. So in a situation like that, in a kid who has, in this situation, an aortic coarctation, had only one carotid, was missing a right carotid, had bilateral vertebral artery lesions, I chose the venous access because the venous access is maybe not optimal, but it's quicker. And I know that in a limited time, I can do something to try to help the hemodynamic status. Now, Dr. Bashat mentioned it, but it's absolutely critical if you take care of these kids to try to save for us the umbilical artery or vein, because this is a highway, you know, compared to the femoral vessels. And here you see we had no access, unfortunately, so this is a direct puncture of a femoral vein, but that's obviously a little bit more difficult than when you can save us an umbilical line. So I went transvenous. This is the MRI that show you the path taken, jugular vein, transverse sinus, falcine sinus, and then it's a complex jugular vein, a complex vein of Galen. You have to go around a few curves, reach the tip of it, and start to coil. And that's where you really don't want to coil too much. It would be easy here to pack the vein completely and take that chance of occluding the deep venous system and basically have a baby dying within 48 hours. So you have to try to do enough to help the cardiovascular status, but not too much to have this kind of complication. So that worked for that first session. We were able to stabilize him, but only for a few days. And at day 18, there was a need for a second session. And that's the way we like to go forward with these children, because again, you don't want to be abrupt. You don't want to do too much at once. So day 18, transarterial embolization. We did only some glue. You can see the glue in the vessel here and there. And that again was successful for a couple of weeks. But then we reached day 30 and we have again unmanageable pulmonary hypertension requiring a third intervention. And on that third intervention, those are lateral views. You see the coils we placed earlier went up through the arteries and coiled a glue one more feeder, actually 2 feeders, and was very happy as we were gluing these feeders. The vital parameters were correcting. We thought we're making a good step forward, and that's always when those vein of Galen aneurysm keep you humble and show you that you do not get too happy too quickly, because even if this looked very good at the end, there was flow through everything. The vital parameters were improved. The follow-up was that. First doing very, very well. The whole day was great. Everybody was happy. And in the middle of the night, there was a seizure. And so after the seizure, we did an ultrasound. We saw hyperechogenic material in the cerebellum. And you can see what the cause of that is. It's a venous infarction of the vermis with hemorrhagic transformation. We did an immediate MRI, and I'm going to put that image of the pre-treatment for comparison. You see what happened here, despite the fact we had some flow persisting at the end of the procedure. This closed completely. The sac, the straight sinus, everything is gone. And so, unfortunately, in this situation, we had some draining veins going into the sac, and we got in that situation of a deep venous infarct. So what do you do at this stage? It's a difficult decision because you have a hemorrhagic venous infarct. But I think the only way to save that baby's life is to anticoagulate. And that's what we did. We started the anticoagulation. And fortunately, this helped. This kept the trickle of flow open. And this is 1 month later with, of course, the sequelae in the vermis, but a surviving baby who is doing well in the sense is discharged, is at home, is evolving, but is not normal. And he still have difficulty eating. Is only starting to eat some liquid food. He has developmental or milestones delay. So we don't know where it's going to end, but this is clearly a more difficult situation. And I will finish with that picture. You heard about the melting brain syndrome. So I think this is I was going to say it's a no-brainer. That's a bad joke, but this is not controversial. You do not treat that. And sometimes we have that question, like, can you do something? Yes, we can actually go and treat that and keep that baby alive. But as you can see, there is very limited brain left. This is all calcified, venous hypertensive sequelae. And I don't think there's any controversy here saying you do not treat that's melting brain syndrome. But so where is and that's a strong or difficult ethical question, where is the barrier? When you look at the prior kid, he survived, he's going to be disabled, most likely. This kid is clearly at the other end of the spectrum, and then you have to decide. Sometimes you have borderline cases, and it's really important that to explain to families in particular that you can always keep, or not always, but often keep those babies alive, but they're going to do extremely poorly. And so we have, of course, better tools and techniques, and thanks to Ahmet and this direct access in utero, we can probably, in those kids with that very large straight sinus, who we know are not going to do well, if they are born like that, maybe we can decrease the flow in utero to prepare a better postnatal management. But we need to remain conscious that still a lot of these kids are in dire situation and won't do very well. And I think that's it for me.